You mentioned the word surveillance, right? I mean, liver cancer is an interesting disease because, like a lot of cancers, I guess it's curable, but you commented on people who are at high risk.
Yeah.
So should we be checking alpha-fetoprotein on people? Is that how we identify this disease early, or any
Yeah.
thoughts on that?
Yeah, so with this identifiable target population and the vast difference in prognosis between early detection and advanced detection, despite advances in the advanced stage, it's really important that we find this early so we can apply curative treatments, like you said. Surveillance is typically recommended using abdominal ultrasound with or without alpha-fetoprotein, and the data suggests that alpha-fetoprotein actually does add something when you use it with ultrasound. And so current recommendations, at least based on the data we have, suggest you should be using the two in combination every 6 months in any patient with cirrhosis.
So, Rena, you're a hepatologist, and you're seeing these patients before necessarily the oncology community does. What about for patients who are obese, from fatty liver disease and NASH? I mean, is ultrasound the perfect test for them?
That's a great point, Rich. You're absolutely right. In that patient population, we're certainly challenged with the performance characteristics of ultrasound, certainly in the obese male population, the growing fatty liver population, and then anytime a patient has ascites as well, these are certainly limitations to the characteristics of ultrasound.
And one of the things that I find frustrating, though I think I understand, is like the U.S. Preventive Task Force. They make the recommendations for screening, colonoscopy, mammogram. Still screening for liver cancer is not something they've recommended. Rena or Amit, can you speak to the reason for that, or?
Rich, the data for surveillance is good, but it's not optimal. So, what we have in the setting of cirrhosis is that we have many cohort studies and largely retrospective cohort studies with limitations like lead time and length time biases. And, when a randomized control trial was attempted in the past, it actually failed to accrue and so had to be shut down. And so I think without this, level 1 data, the USPSTF has been reluctant to put forward a recommendation for HCC surveillance. And I think, we've seen this in other cancers where these recommendations are somewhat rushed out, and then the USPSTF has to pull back. And I think that, given this controversy, for example, prostate cancer screening, breast cancer screening in younger women, I think we're finding that, these organizations would rather have the data be there up front so they make a recommendation and everyone can feel truly confident that that is the right thing to do.